Okay, let me see. Okay, you should be able to see my screen now. Okay, ready. I'm ready. Hmm. Thinking, is it atresia or is it trauma? Probably trauma. Okay, let's see. Uh, oh, it's atresia. Anyway, polyhydramnios refers to an excess of amniotic fluid. Polyhydramnios is associated with fetal development defects that result in impaired swallowing, such as esophageal atresia and encephaly and duodenal atresia. These factors for polyhydramnios also include maternal diabetes, maternal RH incompatibility, and congenital infection. As in this patient, the size of gravid uterus may greatly exceed that which is expected for gestational age, which can lead to maternal symptoms of dyspnea to prevention of diaphragmatic excursion. Diagnosis is facilitated by ultrasound, which will show an enlarged pool of amniotic fluid may be used to assess the amniotic fluid index. Polyhydramnios is defined sonographically as amniotic fluid index greater than 25. Treatment is supportive. Although patients with severe symptoms may be treated with amniocentesis, other complications include prolapse, placental abruption, and rupture of membrane. It is not maternal trauma. Does not frequently cause polyhydramnios. More commonly, it causes placental abruption and fetal-maternal bleeding. The latter could lead to polyhydramnios if the mom was Rh negative and had development of alloimmunization to Rh antigen, which could consequently cause hydrops fetalis in the fetus. However, this patient is Rh positive, making maternal trauma an unlikely cause of polyhydramnios. Okay, next. Suppress adrenal androgen synthesis. Ready? Okay, so it is suppressed adrenal androgen synthesis. Congenital adrenal hyperplasia is a defect in adrenal steroid biosynthesis, particularly of cortisol, with variable effects on mineralocorticoids and androgens. Due to decreased production of hormones, the adrenal gland is stimulated by the pituitary gland to increase hormone production. Okay. Adrenal is in the adrenal gland is stimulated by okay, leading to adrenal hyperplasia, the namesake of the condition. The most common form is CAH of CAH, congenital adrenal hyperplasia, is 25 hydroxylase deficiency, which has various presentation and is associated with an increased level of 17 alpha hydroxyprogesterone, androstenedione, and testosterone. Okay. Classical CAH is caused by complete absence of the hormone and presents with cell wasting in a newborn or precocious puberty in a child, as well as virilization of infants with XX karyotype like clitoral hypertrophy, labial fusion due to increased level of androgen. Other symptoms of classically CAH include hypotension, hyperkalemia, hypoglycemia, and diffuse skin hyperpigmentation. Non-classical CAH goes by decreased hormone levels and is typically asymptomatic in childhood, rather it presents in later childhood or early adulthood um, with signs of androgen excess, such as hirsutism and oligomenorrhea, both of which are seen in this patient. Oral contraceptive and steroids can be used to manage the symptoms of CAH in adult patients. Steroids such as prednisolone therapy used in this patient work by inhibiting, I guess it's ACTH release from the pituitary and consequently suppressing adrenal androgen synthesis. That's all. Okay. Mm-hmm. Doesn't doesn't look like I don't know. It doesn't look like the postures. I don't know. I'm thinking more gonorrhea, but maybe because you wear tampons. Diffuse joint pain. Is that joint pain? Okay, but Stafford tetanus, I know, I guess. So it can be staph. It can be toxic shock also because she has fever. Yeah. Mm. No, it didn't say that. I mean, maybe. Okay. Mm. It's, yeah, it's gonorrhea. But yeah, it could. Yeah. Neisseria gonorrhea gram-negative Diplococcus that can present with a variety of clinical syndromes such as urethritis vaginitis, cervicitis, PID, Fick's, Ugg's, the liver one, disseminated gonorrhea, septic arthritis. When causing vaginitis, the most common presentation, mucopurulent discharge and pruritus, although patients may be asymptomatic. The infection can cause urethritis with dysuria or ascend and cause cervicitis and PID. When infection spread to the bloodstream, it can cause disseminated gonorrhea, which presents with fever, migratory polyarthralgia, tenosynovitis, pustular lesions over the distal extremities. Often, urogenital symptoms are not evident at the time of disseminated gonorrhea. Evaluation should include obtaining culture, blood cultures, NAT, and gram staining culture synovial fluid. Treatment includes antibiotic therapy with ceftriaxone. It is not E. Testing for Staph aureus may be used to the diagnosis of toxic shock syndrome. This syndrome is classically associated with continuous use of tampons and nasal packing and presents with fever, diffuse erythematous macular rash, and distributive shock. Yeah, she don't have the shock. That can lead to multi-organ failure. This patient is hemodynamically stable and does not have the other stigma of toxic shock syndrome. Okay, next. Well, are ANT and AST high? I don't have my papers here. Okay. Oh, but they are high, but not too high, but they're high. Okay. So leukocyte count is high. He has moderate lower abdominal pain to the right of the abdomen. And she has, why? Oh, right. It didn't say right lower. Say right mid. Okay, yeah, she's pregnant. Okay, I get what you're saying. She's pregnant. Yeah, probably. Probably, yeah. Yeah. And she's pregnant, so the appendix is not going to be in the right lower quadrant. Yeah. Ready? Yes, appendicitis. Appendicitis typically presents with, should I read the one now? This one. Presents with right lower quadrant. Right lower quadrant abdominal pain that's often periumbilical at onset with associated nausea, anorexia, fever, leukocytosis, tenderness to palpation in the right lower quadrant on exam. Pregnancy, due to the location of the enlarged uterus, the appendix may be displaced up as because of the, yeah. This displacement limits the classic history and physical exam, which rely on right lower quadrant position of the appendix. For example, initial periumbilical pain is attributed to vague visceral innervation of the appendix. being referred to the midline. Once inflammation affects the parietal peritoneum, the pain becomes well localized to the right lower quadrant, hence the migratory character. McBurney Point, a sensitive location for tenderness of palpation, is located at the, we know where it is. When displaced, when displaced cephalad, the parietal peritoneum inflammation may no longer occur at the McBurney point, even migrating as cephalad as the right upper quadrant, mimicking diagnosis of cholecystitis. Diagnosis is facilitated by CT scan, though it's less used in pregnant women because of teratogen to the fetus. You can use MRI, ultrasound, which may show appendiceal enlargement. The presence of appendicolite, appendiceal wall thickening, periappendiceal fluid. Fluid in the paracolic gutter is suggestive of appendiceal rupture or perforation, paracolic gutter, and is typically accompanied by rising fever and leukocytosis. Immediately, surgical exploration and appendectomy is done to prevent maternal and fetus death or sepsis. Okay, next. Oh, between pregnancy tests and chlamydia, she doesn't have any signs of pregnancy. But do we? I mean, they use condoms, but she's less than no consistently. Consistently. Okay, so then you want to check chlamydia. Okay, okay. I guess let's do chlamydia. You want to do okay? Do pregnancy test. I'll do chlamydia. Do pregnancy test. I'll do chlamydia. Okay. Okay, it's chlamydia. But you see, the person that did they chose pregnancy test too. The person that did the thing. Testing for chlamydia in Nigeria is recommended by USPS, whatever, for all sexually active patients under. I don't know. I feel like we saw a question where he was saying that unless they have symptoms, you don't. I don't know. Maybe I'm wrong. Anyway, under 20. I feel like we saw. It was like unless they have symptoms, don't test them for that. Or what? Or maybe it wasn't chlamydia in Nigeria. I don't remember, but I feel like we saw a question. Yeah. No. Oh, oh, okay. I get what you're trying to. Okay, I get what. No, I missed it too. I didn't. Okay. I didn't choose because. Okay, okay. I get what you're trying to say. Okay, okay, okay. Okay, you think it's just a play of words, the word that they use for that. Mm-hmm. 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 Yeah. Okay, okay. I get what you're saying. No, do you think that's what they use the specific word screening test? Mhm. Okay. Testing for chlamydia and Neisseria recommended by USPSTF for all sexually active patients under 25 years old. Chlamydia is STI that classically present with urethritis, dysuria, dyspareunia, urethral and vaginal discharge. Neisseria STI that presents mucopurulent discharge and pruritus. However, both infections can also be asymptomatic. That's why there is screening. Complication include cervicitis, PID, ovarian abscess, and long-term issues with fertility. Diagnosis is made by NAT. Treatment consists of either azithromycin or doxycycline for chlamydia and ceftriaxone for gonorrhea. And it's not, what is it? Pregnancy test is also indicated for this patient, okay, but it's not more appropriate at this visit than STI testing based on this presentation. If the results of the patient testing for chlamydia and gonorrhea are positive, pregnancy status should then be established to determine safe antibiotic choice. Okay, okay, okay. Got it. Yeah, that's what they're saying. But I think your explanation makes more sense. They specifically ask for screening tests on the question. That's the key. Yeah. Mhm. Next. That's my stroke was 8 weeks ago. Okay. Measurement of fasting glucose. Mm, varicella, rubella. She's pregnant, so not really. So I thought you gave a monoglobulin. I thought no, not give. I thought screen you screen in 28 weeks, not you give, or is it you give? Those things are good. Those things are so complicated. No, you don't. No, you don't do. Yeah, and you don't do. This is not OGTC. This is fasting, so it's not for pregnant women. So you don't. Yeah, it's not that one. Follow up in 4 weeks doesn't make sense. Varicella are live vaccines, so something you give them. Yeah, yeah, it's probably this. Yeah, it's probably the raw. Wait, no problem. Yeah, I guess doesn't matter. No. Oh, prenatal visit. I swear this thing is so complicated. The screening with the for glucose and the raw and the H, it's just it gets complicated. Like anyways, prenatal visits allow for healthcare provide and the GBS thing. It's just anyway. Prenatal visit allows for healthcare provider to optimize a patient's chances to have successful pregnancy and healthy child. Purpose of initial prenatal should be to identify risks to the patient and fetus and to intervene where possible to decrease the risk. Typical assessment during these visits includes evaluating for medical conditions like obesity, diabetes, hypertension, social behaviors like drugs, exposure to teratogen like medication, genetic conditions, or family history of vaccination record. Lab evaluation commonly includes pregnancy confirmation, okay, ABO and Rh type and antibody screen, rubella and varicella serology to ensure immunity, STI infection screening, and urine culture. Okay. Final interventions include folic acid supplementation, abstinence from what drugs, medication, as changes as needed, optimization of medical issue, treatment for infection and asymptomatic bacteria, and early recognition of an increased risk of fetal or maternal death. Most commonly for uncomplicated pregnancy, prenatal visits are recommended every 4 weeks until 28 weeks gestation. Then from 28 weeks gestation, you start every 2 weeks from 28 to 36. And then every week until, oh my God, who's going to remember that? Okay. Anyway. So every 4 weeks until, oh my, oh really? Jesus. Okay, so every 4 weeks until she's 28 weeks pregnant. And then from 28 weeks to 2 weeks. Oh, jeez. 20, I'm trying to find it to make sense. 28 plus 20, it doesn't make sense. During these later visits, screenings for fetal anatomies, gestational diabetes, and group B strep, as well as administration of ROGAM may occur. This patient has a healthy early pregnancy and should return for another prenatal visit in 4 weeks. It's not C ROGAM. Administration of ROGAM is recommended for RHD negative moms at 28 weeks, as well as following the delivery of a positive newborn. Okay, so it's the ROGAM administration they start 28 weeks, not the screening. So when do you do the screening? Anyway, after anyway, this is crazy. Okay, okay. Oh, I get what you're saying. Because they already did the screening here because they know she's RH negative. That's why you're trying to say. Got it. Got it. Yeah, 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 makes sense. Makes sense. Okay. So yeah, after four, so you give at 28 weeks as well as following the delivery, after any invasive procedure, and after any episodes of fetal-maternal bleeding. ROGAM prevents the development of antibodies, blah blah blah. As the development of these antibodies could lead to erythroblastoses fetalis and subsequent pregnancies, blah blah blah. We already know that. Okay, so you give it 28 weeks, then you give it after delivery, and then you also give it if there is some kind of procedure done to the mom, like before delivery, like amniocentesis or all that. Okay, got it. Makes sense. She is 38 weeks and she's having rupture of membranes. And fluid leakage from how long she's been fluid leaking, it doesn't say. Ah, like, no organism, so you don't need prophylaxis for that. So, do we admit for observation? Do we give prophylaxis or do we induce labor? Uh, I'm saying, yeah, I guess, do we give profit like ampicillin or stuff, or do we just induce labor because she's already 38 weeks, or we just observe? I don't know. Yeah, I don't know why. You observe? Okay, let's check. Nope, you induce labor. And this is ridiculous. Anyway, preterm, pre-labor rupture of membrane. No, that's not preterm. Pre-labor rupture of membrane, just PROM. The rupture of the amniotic sac before the onset of labor. Because normally we read it should be the pain, then the contractions, and then the rupture of the vein. Defined as regular contractions with concomitant cervical change. Most commonly, patients report a gush of fluid or steady leakage of fluid from the vagina. Okay. Physical exam will typically show a closed cervix with pooling of fluid in the fornix. Testing of the fluid will show that is nitrazine positive and shows ferning on microscopy. Further assessment should include ultrasound to evaluate for oligohydranus and to determine the fetal position, fetal heart rate monitoring, tochometry, and lab studies to rule out concomitant infection. Okay, so you do ultrasound, and then you do lab studies to check for infection. Complications associated with PROM include intrauterine or fetal infection, such as chorionitis, fetal malpresentation, placental abruption. The risk for intrauterine infection is directly correlated to the length of time between membrane rupture and delivery. For this reason, most patients who present with PROM at term are admitted to the hospital for the induction of labor. It is not B, C, and D. B. Admission to the hospital for IV ampicillin therapy is not appropriate. Ampicillin is typically used in intrapartum settings for the treatment of group B strep colonization in order to prevent neonatal transmission. It is not typically given in a prophylactic manner for patients who present with PROM who are negative for strep agalactiae. Okay, so you give it intrapartum when she's delivering. Admission to the hospital for IV clindamycin can be used in the treatment of chorioamnionitis, which is a polymicrobial infection of the fetal membranes, blah, 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 commonly occurs in the setting of prolonged rupture of membrane as a result of ascension of the vaginal flora into uterine cavity. Maternal fever, leukocytosis, and uterine tenderness are common. However, this patient has no signs of chorioamnionitis, so no antibiotic. So I guess you give it intrapartum too. Admission to the yeah, maternal. Yes, that's what they're saying. And it's not admission to the hospital for observation only. Although many patients who present with PROM will progress into spontaneous, that's what I thought, into spontaneous labor. This occurs with varying amounts of delay based on the patient. As prolonged rupture of membranes associated with significant risk for mother and fetus, and this patient is gestationally at term, okay, the most appropriate next step would be to admission to the hospital for induction of labor. Okay, so if she wasn't at term yet, we may do observation only. But because she can already have birth, she's 38 weeks, we can induce her. We don't give her ampicillin because we don't give ampicillin as prophylactic. You give Intrapac to watch his delivery, and yeah, and then you don't. Then you probably would admit and observe. Yeah, and then you don't give tindamycin because she doesn't have sign of chorioamnionitis. Now, do you give ampicillin for the Sostrepa galactiae as prophylaxis, or it has to be like, oh, she tested positive in the past, so you just give? You get what I'm saying? Mm-hmm. And during delivery, do you give? But so if she already tested, like she tested positive, we gave the antibiotic, we tested again, she was negative. Do you still give intrapartum penicillin? No. Okay. Okay. Got it. Okay. Hmm. That's a good. I wish we could get another question of those, like the GBS. Anyway, 40, yeah, 28. Yeah. Twice yearly. Mm, Between age and cigarette smoking. Age. Okay. Okay. Ready? Okay. So it's oh goodness. Menstrual history. But she says she only has menses like twice a year. Anyway, endometrial cancer most commonly. I feel like we had a similar question like not long ago. Endometrial cancer more commonly presents with postmenopausal vaginal bleeding. What? Which one? Yeah. One. One. Okay. So this one is smoking more. Okay. Okay. But in that other question, what was the answer? No. No, no, I feel like that question we picked menstrual history, but it wasn't menstrual history. And it was like something, it was same thing. Like she was, I don't remember. I don't remember. I don't remember. But I remember we saw questions. I don't remember what. And it was the same thing. I remember it was the same thing. She didn't have menses regularly. It was like, it wasn't regular. So we read on the answer choice, it was like, oh, because it's not regular, then she's not exposed to estrogen a lot because it's not regular. So that's why menstrual is not the answer. Menstrual history is not the answer. I remember. I feel like I remember. So I feel like the answer at that question, I feel like it was age. I think I don't remember. It was. I don't know if it was cigarette smoking. I think it was age, or maybe it was cigarette smoking. I don't know. But I know it wasn't menstrual history. That was not the answer because so that's why I didn't pick menstrual history because it says she only has menses like twice yearly for the past 10 years. Anyway, let's read it. Endometrial cancer most commonly presents with postmenopausal vaginal bleeding, although it can also present with abnormal uterine bleeding in premenopausal women. Abnormal uterine bleeding should be suspected when bleeding is irregular, unpredictable, or not associated with usual premenstrual signs and symptoms like bloating, breast fullness, whatever. These factors include prolonged unexposed exposure to estrogen, such as early menarche, late menopause, chronic and ovulatory cycles like PCOS, exogenous estrogen therapy, nulliparity, and obesity. The next most appropriate step in evaluation of a patient with this presenting symptom is endometrial biopsy to evaluate for the presence of endometrial cancer. If a Let me see, yeah. During the past 3 months. Okay, menarche was 11 each year, blah, blah, blah. She has 4 to 6 months to appear. Yes, I think it was that one. Yes, 2 menstrual histories per year. Yes. Um, Wait, so here, what is the right answer? It was chronic and ovulatory. Okay, and we yeah, and we chose nullipar. We had chosen nulliparity, but it was chronic and ovulatory. Okay, okay. Here it wasn't. There was no smoking thing. It doesn't say she smoked anywhere, right? No, no. There's not here, even here. Okay, so it's chronic and ovulation, but here in our answer is okay. Okay, but here in the question that we're doing right now, the answer is menstrual history. Okay, so I guess it's different. But here, if you read the answer, the explanation for your the question that you just put, it said that it was chronic and ovulation because she only had period like 6 times a year. You see, so that was that. So in our question, she only has period like 2 times a year. So it should be. Oh, yeah, gotcha, gotcha, got got it, got it. Mm, yeah, I know. Mm, Mhm. Mhm. Yeah, yeah. Chronic and overdose. Yeah, that's the question. Okay, got it. So it's not. Oh, can you tell me my phone? Um, okay, okay. So it's the chronic and ovulation menstrual period. Okay. Okay, so it's not age and cigarette smoking. Age is not a risk factor for endometrial cancer. Endometrial cancer primarily occurs in postmenopausal women, especially those over 55 years old. It peaks in patients who are 60 to 70. And it's not cigarette smoking has been associated with decreased risk for the developed weight. Oh, cigarette smoking is associated with decreased risk for development endometrial cancer. By contrast, it's associated with increased risk for cervical cancer. Okay, so smoking is cervical cancer, it's not endometrial. Okay, okay, got it. Next, cervical, yeah, not endometrial. Yeah, like once you are in front of the exam, there is no way you can remember all these like specific like. Yeah, it's impossible. Like you're not gonna remember oh smoky, cervical, blah, blah, blah. I guess the endometrial one makes sense because endometrial like proliferates whatever the I mean the estrogen, yeah, makes sense. But the smoking but the cervical and the smoking, like what does you smoking has to do with the cervix? Like that's the like how you even gonna think about all that during the exam? That's we remember. You know what? I want you to take that exam because I want to be you, you listen. Yeah, you know what? I want you to take the exam so I can after the exam I can be like, Omar, did you remember all these mnemonics while you were taking the exam? Like I just the, hmm, I really want. I'm gonna ask you that the day after the exam. Like I'm really gonna ask you. I'm gonna, I'm, I'm gonna, I'm gonna ask you. I'm gonna call you just specifically to ask you. So how did it? I'm not even gonna ask you how the exam went. I'm just gonna be like, so did you remember this the mornings while you were taking the exam? 'Cause I know the way I get nervous. There is no way. Like mm, yeah. I don't know. It's the day of the exam that you're gonna overcome. Because I don't think that it was bad. It was really bad the days before the exam. It was horrible. But the day of the exam, somehow you feel, I don't know, you feel relaxed. You feel like, oh, okay, fine, it's today. We'll be done with this, and yeah, yeah. But I'm telling you, I'm gonna call you the day after. I feel like you're gonna be like, you know what? I'm just glad it's over. It's over. Like you see. Mhm. No, Galaxy. Hmm. But it's the only thing that makes sense because breast abscess, she will have to have fever. And so mastitis, she will have to have red and painful. Yeah, and it will be red and it will have fever too. Yeah, it's just the galaxy. Fibroadenoma is solid. It's not cystic, it's solid. Galactocele is a benign retention cyst of the mammary glands caused by obstruction to lactiferous duct outflow. Although the fluid in this case is described as clear, typically a galactocele is filled with milk urine. They occur in lactating patients, so patients who recently stopped lactating and present with a firm fluctuant mass that is painless or mildly tender and most commonly presents in the subareolar area. Vital signs will be normal. Diagnosis is typically clinical, but mammography or ultrasound can be performed, which will show a cystic galactocele generally resolve on their own. Treatment is primarily supportive with massage and application of heat. Patients with persistent symptomatic galactocele may need aspiration or excision. Complications are uncommon but include superimposed infections and abscess formation, as well as rupture and inflammation. Next. Oh, okay. So it's DIC. In acute condition, what do you give? It's definitely not red blood cells. FFP. Okay. Okay. I mean it makes sense. Mm, yeah. So it's FFP. The DIC is, oh, let me read it. Oh, never mind. DIC is a systemic disorder characterized by widespread activation of the clotting cascade, resulting in microthrombi formation, microangiopathic hemolytic anemia, thrombocytopenia, bleeding complications caused by consumption of platelet encoding factors. So causes of DIC in pregnancy cannot read the rest. Though laboratory abnormalities reflecting DIC of the clotting cascade, increased PTT, PTINR, consumption of platelets or thrombocytopenia. Additional labs include increased D-dimer and fibrin degradation products and low fibrinogen, along with increased markers of hemolysis like free hemoglobin, low aptoglobin, increased lactate dehydrogenase. Treatment includes correcting the underlying cause and correction of resulting hematologic derangements such as coagulopathy, thrombocytopenia, if platelets less than 50,000 and acute anemia. Coagulopathy can be treated with fresh frozen plasma, which include clotting factors, fibrinogen, antithrombin 3, and plasma protein. Okay. Cryoprecipitate, which is concentrated fibrinogen, or prothrombin complex. Heparin results in immediate anticoagulation, though through binding of antithrombin 3, causing the inhibition of factor 10A and thrombin. It is commonly used for anticoagulation in the setting of DVT, PE, and acute coronary syndrome. Administration of heparin to this patient will worsen her coagulation. Okay, so even my coagulation was okay. Next. Mm-hmm. Mm, so do we do C-section or we give magnesium? Because she already had the seizure, right? Magnesium is for prophylaxis. Okay. Next, let's see. Oh my God. Never mind. Jesus. Just, oh, never mind. Whatever. The cause of this patient tonic seizure is eclampsia. We know that. A complication of untreated preeclampsia. Preeclampsia is caused by abnormality of the placental spiral arteries and poor trophoblastic invasion, leading to placental hypoperfusion and the subsequent production of vasoactive hormones that cause generalized endothelial dysfunction, hypercoagulability, vasospasm. It usually presents in the second or third trimester after 20 weeks gestation with hypertension. Okay. Proteinuria and organ dysfunction like headache, blurred vision, um, right upper quadrant pain, although it may also occur in the postpartum period. Preeclampsia may lead to pteroplacental insufficiency that puts the fetus at risk for fetal growth restriction. If left untreated, preeclampsia can go to eclampsia characterized by seizures. We can have profound adverse effects in the mom, including stroke, cardiac arrest, acute kidney injury, fetal and death, and maternal death. Preeclampsia is treated with antihypertensive, eclampsia prophylaxis with magnesium sulfate, and delivery of the fetus and placenta. Magnesium sulfate is the initial treatment for eclampsia as well as it's thought to increase the seizure rate. As well as it is thought to increase the seizure threshold, it has been shown to improve maternal mortality. Okay, Therefore, the most appropriate next step in management of this patient is administration. Okay, so magnesium is also the treatment for eclampsia. And it, oh, because it's the treatment. I thought it was only prophylactic. Like I thought it was only so the patient doesn't go from preeclampsia to eclampsia, so you give magnesium. But it seems that even if he gets to eclampsia, you still give magnesium because it's the treatment for eclampsia. You get what I'm saying? Okay, let me read that one then. Immediate cesarean delivery may follow administration of max. So yeah, you're right. For patients 34 weeks gestation, eclampsia is an indication for induction of labor if the mom can be stabilized with magnesium sulfate therapy and antihypertensive medication. For pregnancies that are earlier than this gestational age, C-section delivery is often performed secondary to the low likelihood of successful vaginal delivery with induction. Okay, so I guess it's what you say. You give magnesium and then you take her to for C-section. Okay. But yeah, I didn't know the magnesium was also the treatment for eclampsia. I thought the treatment for pre-eclampsia was magnesium and the treatment for eclampsia was C-section. But I guess, yeah, it's the treatment for both of them. Okay, next. Learn something every day. I say you learn something every day with these questions. Yeah, I swear, I feel like I learn something every day with the questions. Right. No slightly, huh? Explanation. Okay. Mm, He said pelvic exam is fine. Okay. Diarrhea, blah, blah, blah. Endometriosis, increased posterior. Pelvic dysmenorrhea. Yeah. Increased prostaglandin production by the endometrium. Primary dysmenorrhea is defined as pain that accompanies each menstrual cycle, but is not associated with a pathology. In order to diagnose primary dysmenorrhea, causes of secondary dysmenorrhea must be ruled out. This may include endometriosis, fibroid adhesions, PID, adenomyosis. Many of these can be reasonably assessed by pelvic exam, which in this case did not show any abnormalities. Primary dysmenorrhea typically presents with pain in the lower abdomen and pelvis that may radiate to the lower back or thigh. It's often accompanied by nausea, diarrhea, headaches, flushing. It can be attributed to uterine vasoconstriction in response to increased prostaglandin production by the endometrium. Uterine vasoconstriction. Okay. Those treatment target this pathway with medications such as NSAID and topical heat therapy. OCPs and progestin IUD may also be used to regulate these symptoms if persistent. I don't understand the pathophysiology of that. It's like prostaglandin, the endometrium produces prostaglandin, and the prostaglandin causes what? Pain. Okay. No. Oh, bradykinin. Okay, okay, yeah. Okay, so but I guess it's the part where it says uterine constriction that I don't understand. Okay, got it. Next, I, I'm so lost. Sclerorectal fossa, intersphincteric, infected episiotomy, infected episiotomy. It was closed in the severe bleeding veins were separated, ligated, blah, 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 into the perineum injection. Filters are in place. Perineum is one. I don't know. Between A and C. Okay, ready? Oh, was A. Infected episiotomy. An episiotomy is a now rarely used incision performed by OBGYNs during delivery that is used to aid in fetal delivery. It may be midline, extending from the posterior introitus toward the anus, or mediolateral, extending from the posterior introitus to the ischial tuberosity. Oh, I get what it is. Um, Most recently, it has been reserved for the expedite delivery of newborns with a congenital fetal heart rate, tracing, or to facilitate operative vaginal delivery with forceps or vacuum. Complications of episiotomy include infection seen in this patient as well as bleeding, extension of the incision, narrowed introitus after repair with consequent dyspareunia, and severe tears with subsequent pregnancies. Episiotomy infections present similarly to other wound infections with pain, induration, and redness. Fever, alcohol, and drainage from the site may also be present. Treatment includes broad spectrum antibiotic therapy as well as possible incision and drainage of the wound. It is not ischiorectal fossa abscess. What is it? Ischiorectal abscess and perirectal abscess and intersphincteric anal abscess are all similar processes that typically originate from the obstruction of an anal gland or an anal fistula. This obstruction and consequent inflammation and infection is broadly defined as perirectal abscess, which is further delineated based on location. Perianal, intersphincteric, ischiorectal. Perirectal abscesses present with perirectal pain, fever, and possible purulent discharge. Physical exam may show skin changes such as induration and redness or areas of fluctuance. This patient has no area of fluctuance on digital rectal exam, making any of these abscesses unlikely. Okay. Mhm. No, no. Ready? Ready? Okay. Okay, so the answer is, oh Lord, 17 alpha hydroxy progesterone therapy. Huh. Normal labor and delivery typically occurs after 37 weeks gestation, with the onset of contraction associated with cervical dilation and rupture of membrane. So it's contraction, cervical dilation, and rupture of membrane. Labor that begins prior to 37 weeks is referred as preterm labor. Risk factors include prior preterm deliveries, maternal diabetes, extremes of age, placenta previa, adrotio placenta, cervical insufficiency, multiple gestations, smoking. The risk for complications in the fetus increases the earlier the preterm labor begins, with these complications including RDS, hypothermia, hypoglycemia, intraventricular hemorrhage, necrotizing enterocolitis. Treatment of preterm labor includes tocolytic therapy, hydration, and bed rest. Tocolytic is to stop the preterm. Okay. Steroids are also given to promote fetal maturity if the gestational age is less than 34 weeks, and magnesium is used for neuroprotection in patients with gestational less than 32. For patients with a history of or at high risk for preterm labor and delivery, such as this patient, progesterone supplementation, 17 alpha hydroxyprogesterone therapy, has been used with some success to prevent preterm labor. Progesterone supplementation is typically started at 16 weeks to 20 weeks gestation and continued until term. It is thought to inhibit uterine contractility in support of the development fetus. So, where you inject progesterone or you just like topical? Oh, I guess. It's, okay. Okay. So it's not. What did I pick? Oh, B or E? It is not cervical seclash refers to the placement of suture into the cervical os to narrow what we know. Cervical seclash is used in the treatment of cervical insufficiency and the inability of the cervix to contain the pregnancy without the presence of contractions, labor, or both. It is not useful in the prevention of preterm labor. Okay. Nifedipine and terbutaline are forms of tocolytic therapy used in the treatment of preterm labor. These agents act to relax the uterine smooth muscle and decrease the frequency and strength of contractions. While tocolysis is an appropriate intervention for the treatment of a patient who presents in Active preterm labor, it plays no role in its prevention. So you give the colitis when the patient is already in labor. Okay, next. Hmm. Between MMR or antibiotics. He has small head and I guess a small body too. So both of them are small. Hmm. Maybe antibiotics. I mean, if this looks more like a chromosomal thing, but okay. Okay, ready? Okay, let's see. Oh, it was measles, mumps, and rubella. Rubella infection is spread by respiratory droplets and can be asymptomatic or present with the rash, arthralgia, post-auricular lymphadenopathy, and fever in otherwise healthy patients. The infection is usually self-limited with no long-term sequelae. Pregnant patients, however, especially when infection occurs in the first trimester, it can cause an infection of the fetus that manifests as cataracts, sensorineural deafness, so hearing issues, and congenital heart defects like PDA, as well as microcephaly. I didn't know the microcephaly. Neurodevelopmental delay and extramedullary hematopoiesis, which manifests as blue-purple maculopapular rash. Infection with the virus is prevented by administration of MMR vaccination prior to conception, as the vaccination is live attenuated, making it contraindication during pregnancy. Ideally, confirmation of rubella immunity with measurement of serum titers should be achieved prior to pregnancy for patients of reproductive age. It is not a year. Administration of antibiotics during pregnancy will not have been likely to prevent this finding. Most infectious causes of microcephaly are viral, like rubella, cytomegalovirus, oh, okay, Zika, herpes, HIV, or parasitic like toxoplasmosis, and thus will not respond to antibiotic. Makes sense. Pregnant patients who do present with symptoms concerning for any of the above infections should be evaluated and promptly treated. Pre-pregnancy vaccination is the most effective method of prevention of rubella infection. It is not B. What is it? Folic acid supplementation during pregnancy is useful to prevent NTDs such as anencephaly or meningomyelocele, but it's not known to prevent microcephaly. Got it. Yes, please. Yeah, ready. Mm, okay, so it is hysterectomy. Okay, I'm right. Cervical cancer classically presents with um, vaginal bleeding with or without sexual intercourse, and an exophytic or friable cervical lesion, although it may also be asymptomatic. Risk factor for cervical include infections with HPV, the high risk strains, early age of onset of sexual activity, tobacco use and contraceptive use, immunosuppression, and infection with HIV or the STI. In many cases, the carcinoma begins in the transition zone of the cell, which is the target region of pap smear, a cytologic screening test of cervical neoplasia. Pap smears are recommended every 3 years for women 21 to 29, maybe 5 years with HPV co-testing in women 30 to 65. The cervical cytology results may be normal, intermediate, or show signs of atypical cells, atypical squamous cells of undetermined significance, or precancerous lesions, low or high, I don't know. An invasive lesion. Treatment includes hysterectomy as well as possible chemo, depending on final staging. This patient has microinvasive squamous cell carcinoma, making hysterectomy the most appropriate next step in management in order to ensure uh, complete removal of the cancer. Okay. Don't think I had another. Yeah, I think it's fine. Okay, so feature fistula, six-stick hygroma. One moment, consistent in size, gestational age. Mm, no, I'm getting it wrong. Okay. Fetal goiter. A mass in the fetal neck is in the setting of maternal thyroid pathology is most likely a fetal goiter. Fetal goiters can be caused by inborn errors of thyroid hormone metabolism, developmental abnormalities of the thyroid, large thyroglossal duct cysts, iodine excess or deficiency, and transplacental passage of maternal TSH antibody like Graves' disease, or transplacental passage of antithyroid drugs such as PTU. Ultrasound of this patient also shows polyhydramnios and excess amount of amniotic fluid defined as amniotic fluid greater than 24. Polyhydramnios can be caused by fetal development defects that impair swallowing of amniotic fluid, such as esophageal atresia, duodenal, and renal. As in this patient, external compression of the esophagus by the goiter. Mm. Transplacental passage of antibodies can cause transient hyperthyroidism at birth until the antibodies are clear. This can occur even in patients who are well controlled with antithyroid medication or a thyroid ablation, as this does not affect the levels of circulating antibodies. However, prenatal exposure to PTU can cause transient hypothyroidism at birth until the drugs are clear. Hypothyroidism. Thus, it is difficult to predict whether this patient will be born hyperthyroid or hypothyroid or euthyroid. Regardless, this hormonal derangement is usually self-limited and resolved without treatment. Severe disease can be managed with methimazole, levothyroxine, respectively. Given the size of the neck mass and its compressive force on the neck structures, the infant may need supportive care to protect the airway and assist with feeding until the goiter has decreased in size. It's not cystic hygroma. What is it? It's not cystic hygroma, it's a congenital lymphatic malformation most commonly found in the neck. It may be isolated or associated with chromosomal abnormalities such as Turner syndrome, Down syndrome, Noonan syndrome. Polyandrinus may occur if the mass grows large enough to obstruct the fetal esophagus. However, in this case, with maternal thyroid pathology and use of antithyroid medication, the goiter is most likely. It's not tracheoesophageal fistula often occurs concomitantly with esophageal atresia and is thus associated with polyhydramnios as the esophageal atresia impairs whatever. Yeah. Tracheoesophageal fistulas are usually not visible on prenatal ultrasound and do not present as visible neck mass. Okay, next. Mm, it's probably placenta previa, but I'm wondering because the fetal is not in good presentation. But he's not in unstable, but so everything is normal in the fetus, but it's still placenta previa. So yeah, so placenta previa normally is managed with C-section, but is only 30, wait, 31 weeks, but the baby, the fundal height is 34. Oh, that's weird. So but the fetus is fine. So do we just monitor or do we induce? No, I mean, we cannot induce because she's placenta previa, never mind. So do we just do cesarean delivery or do we monitor? Patient, yeah, okay. Okay, so it's IV administration of fluids and observation. Placenta previa refers to abnormal position of the placenta tissue, such that the placenta is partially or completely covering the cervical os. Most commonly presents with painless third trimester vaginal bleeding. Frequently is detected on prenatal ultrasound, but it may not always be evident. Thus, patient who presents with vaginal bleeding after 20-week gestation should not undergo digital cervical exam until ultrasound has been performed to determine the exact position of the placenta, because severe hemorrhage can occur if the placenta previa is present. These factors for placenta previa include causes of uterine scarring, such as multiparity, previous C-section, prior dilation, and correctness. While it may self-resolve as pregnancy progresses, it's present in the late third trimester requires careful management. Treatment of an initial bleed without significant hemodynamic stability, such as this patient. You give IV administration of fluids and observation. Patients who are able to stabilize may be expectantly managed with a plan of C-section at 37 weeks to allow for time for fetal development. C-section is indicated to prevent significant hemorrhage or whatever. Blah, blah. Immediate C-section is advised for patients who present in labor or those with hemodynamically significant bleeding. It is not Immediate C-section is not necessary if the patient remains hemodynamically stable and her bleeding is able to be controlled. Placenta previa does not necessitate immediate C-section if a patient with a non-placenta previa presents in wait, placenta previa does necessitate. So you must do immediate C-section if a patient with non-placenta previa presents in active labor or with uncontrollable bleeding associated with hemodynamic instability. Okay. Yep. 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 Next. Okay. Ready? I think so. Um, mm, I think that an ovulation, hyperandrogen. What was the third one? Oh, BMI. Okay. Ready? Testosterone. Yes, PCOS. PCOS present with irregular menses, infertility, and insuticin. So problem with menses, high testosterone, so men stuff, and then what was the third one? Oh, BMI. Yeah. And irregular menses, infertility, and hirsutism, often in patients with increased body weight. Requires two of the following for diagnosis: oligoanovulation, so issues with menses, PCOS on ultrasound, and clinical or biochemical signs of hyperandrogenism. So two of it. It is associated with signs of insulin resistance, such as acanthosis nigricans, and increased blood glucose. PCOS is associated with abnormal hypothalamic hormonal feedback response, which leads to increased LH in comparison to FSH, as well as markedly increased androgen production from the thicker lutein cis. This results in increased serum of testosterone. Treatment includes weight loss, OCPs for menstrual regulation, and spironolactone and ketoconazole for hirsutism. Clomiphene stimulates ovulation and can also be used for patients with desiring pregnancy. If the patient is diagnosed with diabetes, oral medication like metformin and insulin may also be necessary. Potential complication of long-standing PCOS endometrial cancer due to chronic anovulation, resulting in prolonged exposure of the endometrium to unopposed estrogen. When they say chronic anovulation, when they say whatever, when they say anovulation, that means that there is estrogen that proliferates, makes the endometrium proliferate. But why do they call it anovulation? Yeah, Yeah, what is the pathophysiology of an ovulation? Okay. Hmm. Okay. If what does not happen? 15 months. Okay. Hmm. Hmm. So when there is ovulation, there is no estrogen rise? Mm. Okay. O- Okay. So when there is an ovulation, there is no menstruation. So the hormones stay high. Mhm. Got it. Got it. Mm-hmm. 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 Okay. Makes sense. Makes sense. Makes sense. Okay. Next. It's some kind of, she's less than 20 weeks, so some kind of those abortion thingies. The those abortions, the ones with I forgot the names, but the different ones. Inevitable or those yeah, those inevitable this. I don't know which one specifically, but it's one of those. Um, so do we give projects? Because we just saw a question that's yeah, but this is not septic abortion. And this is you don't do I don't think you need section and curettage here. It says the fetus is there. Yeah, it's not here. Yeah. And so I'm wondering if it's progesterone because we just saw a question that says that in order to premature for premature yeah yeah to prevent premature thingy, but it can also be the RH factor thing because she just had a bleeding. Or do I don't know, whatever. Let me just pick one. Let's see. Okay, I picked the RH factor, but I feel like it's the progesterone. Okay, it's the RH factor. RHD negative moms are at high risk, oh my God, of developing anti-D antibodies if exposed to blood from a positive fetus, which most commonly occurs during delivery. However, it can also occur during episodes of fetal-maternal bleeding during pregnancy, such as in this patient, likely has secondary to a preterm abortion. Yeah. If RHD antigens from the fetal circulation enter the maternal, it's possible that the maternal immune system will form antibodies against Rh antigen. This can result in severe hemolytic anemia, aristoblastosis fetalis, if the fetus is Rh positive. As maternal antibodies, we already know that. RHD immune globulin acts by binding to, we know how it works. Okay, administration of ROGAM globulin is typically performed for RHD negative moms at 28 weeks gestation, along with following delivery of a RHD positive newborn, any invasive procedure like amniocentesis, and any episodes of fetal-maternal bleeding. Therefore, the most appropriate next step in management is to determine this patient blood type and RH factor, so she may be given the program. It is not CND. Where is it? CND. Intramuscular medroxyprogesterone and oral progesterone can be used as hormonal contraceptive. Um, yeah, progesterone acts to maintain the secretory endometrium and prepare it for embryo implantation, as well as decrease uterine contractility in support of the developing embryo. As such, estrogen therapy is occasionally used to prevent recurrent early pregnancy loss or preterm labor in those at increased risk. Okay. Progesterone will not be appropriate in this patient because that's her first pregnancy. Okay, got it. Mm-hmm. 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 At 28 weeks, yeah. Okay. Oh, in this case, you'll give it now because she had that whatever thing she had, the bleeding, and then you'll give it at 28 weeks, and then you'll give it again, I'm guessing, during delivery or after delivery, sorry. If I understood well their explanation, I don't know, correct me if I'm, but the way I understand the explanation, since she just had the whatever thing, the abortion, the threatened abortion, if she's RH negative, you'll give the ROGAM now, then you'll give it again at 28 weeks, and then you'll give it again after delivery. If I understood, if I'm understood, 3 times. That's kind of how I understood it. I don't know if that's what they mean, but that's kind of how I understood it. Okay. Do you want to continue or you want to do biostat? Or you want to finish this one? Yeah, can you hear me? I said, do you want to continue or do you want to you want to do biostat? Because it's okay. Yes. Yeah. Lot. Okay, positive predictive value. Wait, is this the question? Yeah. Okay. Let me I'll read, I guess. I six question. Okay. Wait. They're asking for the positive predictive value. Positive for the test and forgot what it was. It's too positive over what? Positive predictive value is too positive over what? False positive. So it's 80 over 90. Let me see. Calculator. 80 over 90 times 100. 80 each. 80. This don't even make sense. Let me see. You say it's true positive over false positive. True positive, false positive. False positive. False positive. False positive will be positive, but is unaffected. Yeah, it will be 80 over 90 times 100. It is not. Okay, I'll just pick one. This doesn't make sense to me. You sure it's false positive? It doesn't make sense. Anyway, I'm like, you sure it's false positive? Okay. Way to remember. Okay. Hmm. Just, why? You say 80 divided by 90? Wait, you say false positive. False positive, wouldn't that be 10? But oh, I don't get it. Okay. Okay. No, I mean, at least you found something that's inside the answer choice. I didn't even find anything that's inside the answer choice. So I thought 10% was because it says positive result and negative in uninfected patients. A positive result in uninfected patient is false positive, right? Or am I wrong? Okay, yeah, okay. Okay. Um, I thought it was negative predicted, but maybe it's a specificity because he said she's saying probability of, oh, what are the chances that I really do not have the cancer if the result is negative? So result is negative, patient don't have it. So you're starting with the result, not with the patient. I'm thinking. That's what I'm thinking is negative. Oh, remember how I had told you sensitivity was patient has the disease and the test is positive. Specificity, patient don't have the disease, the test is negative. Positive predictive value, the test is positive and patient has the disease. Negative predictive value, the test is negative, patient does not have. So in one you start with the patient, in the other one you start with the test. Does it make sense? Okay. Don't, do you understand it like that? Does that make sense when you understand it? Because for me, it doesn't make sense when you say it like that. No. I don't know. It doesn't make sense, but I mean, these people want. Okay. I mean, if you understand like that, it's good. I just don't understand it like that. But you cannot remember my words. So in okay. Oh, you want me next? Okay. 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 So with one with specificity and sensitivity, you start with the patient and then you go to the test. With predictive value, with specificity and sensitivity, you start with the patient and then you go to the test. With predictive value, you start with the test and then you go to the patient. So specific, and then you can match specificity with positive predictive value. So specificity, we start with the patient. Patient is positive. Oh, sorry. Patient has the disease, so the is positive. Now contrast with positive predictive value. Disease is positive and patient has this sorry. Oh my god. But test is positive, patient has the disease. You see, it's the same thing. It's just the wording that one starts with you see what I'm saying? Okay. And then sensitivity with negative predictive value. Sensitivity. You start with the patient again. Patient don't have the disease and the test is negative. So predictive value. Test, you got it. Yeah. So in once you start with the patient and in the predictive value, you start with the thing. So here in the question, I thought that I'm thinking that he's starting with the test. And he's saying the test is negative. So there is a big chance that you do not have the disease. That's why he predict negative predictive value. But maybe I'm wrong. Maybe you're right. And that's why I was saying maybe you're right, because maybe he's actually starting with the patient and he's saying you don't have the disease and your test is negative. So that's why I was like, maybe you're right also on that one. Mm, the specificity will be the people that don't have the disease and test negative for the disease. I don't know. Positive predictive value will be the people that have a positive test for the disease and have the disease. So that will probably increase because the age is a drug users. So that will increase. So we can eliminate these two. A negative value will be people that test negative and do not have the disease. Oh, Señor Jesus. Okay, so it's between A, B, and C. At least we took out two, so that's already something. Okay, we just need, we just need to take that one. D or E. Oh no, no, we already took out those. Okay, people that don't have the community has a lot of Hep C because they are IV drug abusers. So people that test negative don't have the disease. Maybe they will decrease because it's a lot of people that maybe they will decrease. Okay, I'll pick D. I'll pick B. I'm not sure, but I'm picking. And specificity. Don't go with me. Pick between A or C. We know it's one of the three for sure. I cannot tell you that. Yeah. Oh God. Oh, bastards. Okay. So people that test positive have the disease. Positive have the disease. X to A. Increase. Okay. Oh shoot. I think it will increase. So you say it will decrease? Where? Why are you doing false positive? But they're asking for the positive predictive value. So why are you doing over? Oh, I get what you're saying. So false positive. Makes sense, makes sense, makes sense. Yeah, from the formula, I get what you're saying. Increase false positive, false positive. Yeah. No, it makes sense. It makes sense. Makes sense. Mhm. I don't know. I don't know what they're asking here. I don't know. Mm, I don't know. Is it one is supposed to be the screening test and the other the I don't know what really they're doing. By coronary. Okay, I guess one is supposed to be the screening test and the other the. Okay. Oh no. Negative ECG stress test. What is the probability of having a positive coronary antenna? Listen, I don't understand this question. I just want to pick one. I don't understand this question. Um, Next. Highest predictive value. Test positive. The patient is positive. Yeah. Sorry. Yeah. Okay. No. Let me see. Okay. Yes. Yeah. Mm-hmm. Um, yeah, kinda, yeah. Mm-hmm. 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 Okay, that makes more sense. Makes sense. Wait, what's the answer? What's what's the answer for five? Oh, 13%. I don't get that thing, but okay. So they're saying it's NPV, negative predictive value. So it should, I don't get that shit. I don't know what you're saying, but Mhm. Yeah, yeah. I don't understand the five and six question.